Welcome to a new episode of Endocast and this new season. So, today we are going to have a special topic which combines two specialties. And also, we will have two special guests.
Ladies and gentlemen, please welcome Professor Marc Kaloustian and Dr. Claire Hachem. They are from Lebanon, St. Joseph University, practicing in Lebanon and part time in UAE. So they will be present with us in this episode to talk about the endodontic treatments in children. And this is a very, very important topic with a lot of challenge. So, hi Mark, hi Claire, how are you?
Hi
Hi,
guys.
hi guys. Hi Ahmed. Hi Francesca. We are good, very good. It's an honor for us to be here.
And it's a great
Thank
combination. I mean, a pedodontist and an endodontist. And I think there are a lot of common aspects in the professional and academic career. So, can you tell us, Mark and Claire, how you both get the best from such a close professional fields for providing a good standard or care in your practice as well as research?
Well, we are in a new era in dentistry in general. It's the era of conservative dentistry. A few years earlier, on children, they used to extract lots of teeth. Now, pediatric dentists and endodontists, we are trying to save the teeth, even on children, even for primary treatments, because it's really traumatizing for children to remove their teeth. And also, the best space maintainer, you agree, I think, Claire, is the real primary tooth. This is why we both work sometimes on children. We are in the same practice, and Claire has lots of patients with deep decay on primary teeth, sometimes with necrosis, where we need to do root canal treatment, or even on permanent teeth, immature teeth, where we need to do
And
permanent
mixed dentition.
exdentation. So, and sometimes the patients are very difficult. So in these cases, we work together. Uh, I will do the endodontic part. She will do the sedation part, the talk with the patient, and after she can also do the crown, so the post endo. So, and concerning the research part, we are both at the St. Joseph University, and we are both interested in research. We work with students. It's a great opportunity for us because when we work with students, they do thesis, and we have to help them to do some research in this field. I don't know if you have.
We are both post-grad program directors at our university in both departments. So at the moment, we are conducting a lot of studies on new materials, on pulpotomy, on immature permanent teeth, and a lot of studies about combining the endo-pedo together.
Well, that's really important for both specialties to have just such combination in research, especially just to open the avenues for both endodontists and pedodontists to know how can we integrate both specialties for the good of the patients. So let me start chronologically when we're speaking about the primary teeth or the mixed dentition. So we will start with primary teeth. So, Claire, pulpotomy is a very common procedure in primary teeth. Even without such severe symptoms of pulp involvement, so can you tell us about the workflow in primary pulpotomies from case selection to diagnosis and the clinical steps?
Yes, so pulpotomy is probably the most done procedure in any pediatric clinic. And the procedure is always the same. First of all, the case selection is caries nearing the pulp without any signs of infection, without any signs of radiographic radiolucency, or without any signs of swelling, necrosis. So it's caries nearing the pulp or mechanical exposure during the excavation. So we start by doing case selection and then anesthesia, asepsis, rubber dam isolation, access cavity opening. We need to see that there is light bleeding. And then we place our material. Today we are doing pulpotomy with new materials, biocompatible materials like MTA, biodentin, calcium silicate materials, and then we place a crown, coronal seal. This is how the flow is usually in every pulpotomy case.
Okay, so when the situation is a bit more complex, you just switch to pulpectomy. In which cases you go for pulpectomy and how you do it in primary teeth?
So, whenever dealing with children, the pulpal diagnosis is very difficult. This is why we often rely on the clinical situation. So, whenever we open a tooth and we see there is excessive bleeding, excessive hemorrhage, or there is no sign of bleeding from one or all the canals, we will go for a full root canal treatment or pulpectomy in an attempt to save the tooth because we don't want to extract if we can save the teeth. The pulpectomy is basically a root canal treatment like we do on permanent teeth, but it's done on a primary tooth. So we start by selecting the case, like we said, irreversibly inflamed pulp or necrotic pulp. Uh, Anesthesia, isolation, access opening, working length determination, and yes, we use the same technologies that we use on permanent teeth. Like we use apex locator, we use rotary instrumentations with, of course, a small taper. And then we disinfect a lot because there are a lot of lateral canals, accessory canals, or primary teeth. And we obturate the root canal system with a resorbable filling material. So this is the main difference between a root canal treatment on a primary tooth and on a permanent tooth. It relies more on the disinfection rather than on the shaping. And at the end, of course, always we have to do the coronal seal immediately to increase the prognosis of the treatments that you are doing.
That's good. That's perfect and perfectly explained. So I have a question because I see a lot of controversies regarding pulpectomy, even in some Western countries, because in some schools they prefer just to adopt a more radical treatment like extraction instead of doing pulpectomy. For pulpotomy, it's okay, but for pulpectomy, not all schools believe in the pulpectomy. Can you just explain these controversies about pulpectomy versus extraction? Why it is elaborated like this?
Yes, of course, and this is something that we face even with our referring dentists or with the parents. Actually, we should always weigh the plus and minus of the treatment, meaning pulpectomy is not an easy treatment to do in children. It requires to have proper tools like rotary instrumentations, to be equipped with all the tools to do a root canal treatment. And we need to have a very cooperative child. This is the most important part. So it's not indicated for all children. Like for children at very young age who can't handle long treatments, we will not be able to do pulpectomy. And also, the root canal anatomy of primary teeth is very difficult because it's continuously changing. There is the resorption, and then there is apposition, there is stability in the roots. So the anatomy is very difficult. But today, we can say with evidence that pulpectomy is a treatment that works. We know that we can keep primary teeth for a long time, teeth with the signs of sinus tract, necrosis, infection, if we do step by step good pulpectomy treatment from the case selection to the asepsis part to the shaping, disinfection. All the sequence should be done in a reproducible way, in a correct way, to be able to have a good pulpectomy. For example, I can do a pulpectomy treatment on a child that is anxious, that is moving a lot. I will not be able to do a good pulpectomy treatment. So always weigh in the success versus the practicability of this treatment, I think.
Yes, I agree with you because if you cannot do the proper treatment, then it will fail. So it's better to remove the tooth, and vice versa. If you have all the good aspect for the treatments, the workflow and everything, so it is working. So it's based on how you are going to perform the procedure. That's very nice.
Well, one of the questions that I had for Claire was, what about the cases when you have a lesion? And what about the final restoration for these teeth?
Okay, so for the lesion, what we should know is that on primary teeth, the lesion is not seen on the apical part like on the permanent teeth. The lesion is between and the furcation area, because this is where we have the communication, and this is where we have a lot of lateral and accessory canals. So whenever we see an image with a lesion, it will be located in the furcation area and not on the apical area. So what we look for when we see a radiograph of an infected primary tooth. And we know that when we do a good pulpectomy treatment, the healing potential in children is very high. And the response is very quick. Sometimes within 1 week, 2 weeks, the healing is clinically is perfect. Of course, radiographically, the healing takes more time, but we do have evidence of healing. For the final restoration, and this is, I think, the most important part, because sometimes our treatment is not 100% perfect. But if our coronal seal is adequate, we will increase the prognosis of the treatment. And this is why in children, when we do pulp therapies, whether pulpotomy or pulpectomies, we should always place crowns. And this is also what is recommended by all the guidelines, all the issuing authorities in pediatric dentistry, to place crowns. It can be a stainless steel crowns, which is still the most durable restoration for children, or it can be a zirconia crown, a 3D printed crown, a bioflex resin crown. We have a lot of crowns today. But what's important is to be able to finish the treatment in one session.
Okay. So before I move to another point, I just had a question in my mind about the type of the obturation material. Would it be different in vital pulpectomies from the necrotic cases with lesions? Is there any modification in the filling in pulpectomy in both cases, or they are just the same? And what is the filling material?
This is a very interesting question. Actually, whenever we have a lesion or a big infection, it is recommended to place materials that contain calcium hydroxide and iodoform inside the root canal system. But in general, we don't have a lot of choice of filling materials on primary teeth, because we want a resorbable material, an antibacterial material, and a material that doesn't irritate the periapical tissue. So we either can use zinc oxide paste that we mix, powder liquid, or calcium hydroxide with iodoform. Whenever we have a lesion or a big swelling, it is recommended to opt more for the calcium hydroxide with iodoform. And today there is an ongoing research about non-setting bioceramic materials for primary teeth. And I know some people are really trying to push for this. Maybe this will be the future of obturation in primary teeth.
Yeah, I heard about that, and it will be not only non-setting but also resorbable. So
Yes.
we will see in
We
the
did
coming
actually
days.
a study about that field. There is some images that you that are in the presentation where we
Yeah,
used some bioceramic sealer experimental to see how it works inside the root canal system.
yeah. I will move later to that point, of course, because I saw the images and I was interested to know what are these in primary teeth with the bioceramics. So we will discuss that shortly.
I have another question, Ahmed, if I can, because
Yes.
yeah, I know nothing about pediatric dentistry, so guys, forgive me. How long in teeth with lesion do you wait for the healing, in order to decide that maybe that tooth has to be extracted. Because it happens in everyday clinics. You see the child, it has a lesion, you do the treatment, and maybe after 2 months, there's a sinus tract again. So what do you do? Do you extract? Do you redo the treatment?
So this is actually something very clinical that we face a lot. This is why case selection is very important. We need to tell the parents and make them understand that what we are trying to do is to save the tooth, and we are doing our best to save the tooth. We cannot guarantee 100% success, but we can try. And this is what I tell them. We can always try, and it's better if we can keep the tooth. Usually, I will wait at least 6 months before deciding on extracting a tooth. But like I said before, the reaction in children is very fast. So if there is failure, the child will be in a lot of pain, and there will be swelling and fistula and sinus tract very quickly after the treatment. And if there is healing, it will also be very quick. But if we are confident in what we are doing, and if we explain to the parents what we are trying to do, then we can expect good healing and good results. And we know from the literature that the success rate of pulpectomy is more than 90% on primary teeth when it is done correctly.
And there is a difference between the success rate on primary teeth and the success rate on permanent teeth. We have to remember that here we are talking about short-term success rate, because these teeth will be resolved and replaced by permanent teeth. And concerning the retreatment, there is no possibility of retreatment in primary teeth. So if it doesn't work, yes, we have to go for extraction. You know, the anatomy of the tooth is very, the roots are very thin, so we cannot go again and clean again and do again the treatment. So if it doesn't work, we have to go, of course, for the extraction.
But extraction, this is what I always tell the parents. At any time, we can do extraction. Extraction is a treatment that takes 1 second to do. But the repercussion of extractions, and especially in very young children, is really, really catastrophic from a psychological point of view, and also how they chew, how their maxilla and mandible will grow. So if we can try to preserve the teeth for as much as possible, this is always the option that we go for.
That was clear. Mark mentioned about some challenges in the anatomy, the complex anatomy, and when we're talking about endodontics, even in primary teeth, I think the anatomy can even be more complex. So, how to properly address the anatomy in pulpectomy, and what are the challenges that can face the clinician while doing this, and which parts to take care about?
Yes, Ahmed. So, as you mentioned, the root canal anatomy of primary teeth is very difficult. And what we are seeing here is a reconstructed micro CT image for one of the studies that we published some years ago. And you can see the isthmus connecting the canals, that is a continuous isthmus. So, of course, disinfecting this root canal system is not something easy. But today, with the tools that we have, we are able to disinfect as much as possible this root canal system. So, of course, the like Mark said, the roots are very thin. So the possibility to do a stripping or a perforation is very high. This is why before starting any pulpectomy treatment, we need to understand the root canal anatomy of the tooth we are dealing with. Whether it is a molar, an anterior tooth, it's not the same.
So as you
Okay.
can see, yeah, as you can see here, we have lots of anastomosis, even more than on permanent teeth. So when I think we will talk about it later, but when we work on primary teeth, we have to forget a little bit the concept, the paradigm of the taper and so on, because
Yes.
we have to remember that our obturation is not a GP-based obturation. it's a single paste obturation. So it's another concept. On this image, you can see how thin is the roots.
Yeah, so this is also a cross-section micro CT slide where we actually studied the diameter of primary teeth at different levels. And this I think is either a coronal or a middle section. And you can see the dentine thickness all around the tooth and how thin it is on the furcation side. And why is this important? Because this is where what we call the danger zone when we are doing our shaping. And this is where it's, if we don't know the characteristics of the instruments that we are using, the metallurgy and the movement, we can do a lot of damage and there will be a lot of extrusion of filling material when we are finally doing the obturation. So it's important to know the anatomy and to read about the data available, what is the dentine thickness, and this will help us in choosing the most suitable instrumentation, rotary instrumentation or reciprocation, whatever, uh, in a safe way, not to endanger the permanent tooth.
You can do the experience of taking an extracted primary molar and place a file inside. You will see, if you go in the mesial canals, you will see by transparency the file, because this wall on the furcation side is very, very thin. So we need to use instruments that have very small taper, like 4% taper or even smaller taper, remembering always that we have to rely more on disinfection. Maybe we'll talk about it a bit later, more on disinfection than on shaping.
Yeah, exactly. And this is what I really wanted to ask you, Marc. What is your input about how to have an efficient disinfection and activation protocol in primary teeth in the light of the important information that Claire has just given us?
Well, this is, I think, the crucial question, the most important question, because we have a big difficulty. We have two difficulties. First of all, the anatomy. Second, we cannot shape too much. Then we have to do irrigation. Our irrigation protocol should be the same as for adults. We will use sodium hypochlorite at the beginning, full strength, of course, and then we will use EDTA at the end to remove the smear layer. But we have to remember that we are working on a child. On a child, I cannot spend 1.5 hours to do a molar. I cannot spend even 1 hour to do a molar. We have to do it very quick. The entire treatment should take 30 to 45 minutes. Because the child cannot stay on the chair for that long. So this is why we have to do very quickly our minimal shaping, very minimal shaping, and then start very quickly our irrigation, and of course the activation of the irrigation. A good shaping, for example, can be do with the XP Endo Shaper or XP Endo Rise, because it's very minimal shaping, or 3% instruments or 4% instruments. And then we have to enhance this irrigation by using ultrasonic PUI, or, for example, here we can see on the first, it's the XP Endo finisher, mechanical activation. Start this disinfection very quickly to take advantage of the 20 minutes of the disinfection that we need to have a good treatment, as we all know.
Yeah, that's interesting, because I want to ask you something that came in my mind about the selection of the tool, because sometimes the anatomy is very difficult for a stiff instrument like the stainless steel tips for the activation. So shall we select something more conservative
Sonic.
as well as less dangerous?
You know, they have the particularity of the anatomy of these teeth is, I'm talking about the molars, is they have a middle important curvature. So you are right. Sometimes it's very difficult with the PUI to go deep inside, but at the same time the roots are very short. So we are talking usually about 15 to 16 millimeters of entire root length. So the activation can be done with sonic, Sometimes ultrasonic night eye, for example, can be also used to
Oh,
do the
yeah.
activation if the curvature is not very, very important. And also, what I like a lot is the finisher, as I told you before.
Personally, I prefer the Sonic because I'm
Yeah,
not too confident about the tips going into some complex anatomy. So Sonic or the mechanical activation would be really a good option. So
yes.
the final step, and you mentioned something about it, is the obturation and coronal seal. So we want to know the current status and future perspective of obturation, and if you can give us some information about what you said about the bioceramics, that would be good for the followers.
So yes, the bioceramic is now
Trend.
a trend, as we know, but it would be a very interesting alternative in primary teeth. When I did some studies about an experimental bioceramic, non-setting, resorbable bioceramic material, what we saw actually on the micro CT reconstructions is a lot of voids. Of course, because we don't have the support of a Gutta Percha cone here, we are talking only about the material alone. And we see a lot of internal voids and external voids. And these material, as we know, are also very soluble. So we don't know clinically if they will remain inside the canal for a long time. If I do, for example, the treatment on a child that is 4 years or 5 years old, and I need this tooth to stay for 5, 6 years, I'm not sure that for now this kind of material will be able to not wash away from the canals when we start to have a resorption outside. So, still a lot of questions about the use of bioceramics in primary dentition. But if we can combine the properties of bioceramics and uh, overcome their disadvantages, I think they will be a very interesting prospect in the obturation of primary teeth. Look at the difference. This is the basic zinc oxide eugenol material that's been around for 100 years. Look at this,
The density of the
the
objection.
density of the obturation and no
No
voids at
voice.
all.
That's interesting. So it will be a debate between the new material and the old classic material, like it has been done previously between the composite and amalgam. So maybe we we will have a
Yeah,
fight for some years about.
These are also digital microscopy images that show also the voids when we are using bioceramic. And of
Bye.
course, we know that not all voids are the same. When it's an internal void, it's not really a very big problem. But when the void is in the interface with the dentine, this is a portal of entry for bacteria and question mark for how long my treatment will be a success before I have an invasion of bacteria again. I always wonder if we can do a resorbable cone for the obturation of primary teeth. I think this will solve a lot of problems.
Yeah, you have
I,
to do that.
Yeah, you can work on that.
I think they tried to do calcium hydroxide cones, but it didn't work very well a few years ago.